Welcome to the deep dive. Today, we're tackling something that definitely causes some worry. Brown recluse spider bites.
Yeah, we're digging into the treatment side, mainly using Chapter 76 from Hyperbaric Medicine Practice as our guide.
Right. We want to pull out the key info you need to know about this.
Exactly. We'll cover the spider itself, what's in that venom, why diagnosis is so tricky, and then get into treatments, including hyperbaric oxygen.
Okay, let's start at the beginning. The brown recluse spider. It was first documented way back 1872.
That's right. And early on, they noticed some, pretty serious systemic things: fever, jaundice, blood in the urine after bites.
But the skin reaction, the necrotic lesion, that came later.
Yes. Here in the U.S., the connection between the bite and specific skin issues, the pain, swelling, the characteristic rash, was made later. They linked it to something similar seen in South America, the gangrenous spot of Chile.
And that's where Loxoscelism comes from.
Precisely. It refers to the effects of envenomation by these Loxosceles spiders.
What's really interesting, maybe a bit concerning, is that even after, 5 decades of knowing more about the venom, there's still no single clear-cut treatment everyone agrees on.
No, absolutely. There's still quite a bit of controversy, which really tells you how complex this whole thing is.
Definitely. Okay, so let's get acquainted with this spider first. Where do they actually live? I mean, are they everywhere?
Well, you hear reports from all over New Jersey, California, even Hawaii sometimes. But the reality is they're primarily concentrated in the South Central U.S.
South Central.
So, think Western Florida,
Yeah.
across to Eastern Texas, and then north up into Illinois, Southern Iowa. That's the main zone.
So if you're outside that area and have some kind of, nasty skin lesion.
Exactly. It's much less likely to be a brown recluse. You should really be thinking about other potential causes first. Bites outside that core region are, pretty rare.
Okay. Location is a big clue then. Are they aggressive? Are they hunting us down?
No, not at all. They're actually quite reclusive, as the name suggests. They like dark, dry, undisturbed places.
Oh my God.
Outdoors, maybe under rocks and wood piles, debris. Indoors, think basements, attics, closets, storage boxes, those kinds of spots.
Yeah.
They really only bite if they feel threatened or trapped. Like if you roll over on one in bed, since they're nocturnal, or put on clothes it's hiding in.
So it's accidental contact usually.
Pretty much. And they're surprisingly tough little critters. They can survive months without food or water, live maybe close to 2 years.
Wow.
And the peak time you see bites tends to be between April and November.
Okay, tough and patient spiders. How do you actually ID one? Because, any small brown spider could cause a panic.
That's a really important point. Size-wise, they're about 1 to 5 centimeters, leg span. Color is fawn to brown.
And the fiddle? The violin shape?
Yeah, the famous dark violin or fiddle shape on their back, on the cephalothorax, just behind the head. That's the classic sign, the fiddleback. But, and this is key, lots of other spiders have similar markings. It's very easy for someone who isn't an expert to misidentify them based just on that.
So what's a better clue?
A more reliable feature, though still hard to see without magnification, is their eyes. They only have 3 pairs, 6 eyes total, arranged in a sort of semicircle.
Unlike most spiders with 8 eyes, 4 pairs.
Exactly. Most spiders have 8. But even this isn't unique. Some other spider families, like cytodes, have 6 eyes too. They also have long, thin legs and can move fast.
So, bottom line, location, maybe the eyes if you can see them, but really expert confirmation is best.
Definitely. If you can safely catch the spider, even if it's crushed, an expert might be able to identify it.
Got it. Okay, let's talk venom. What makes the bite so nasty?
Right. The venom is, it's a complex mix. We learned a lot in the 70s, but we still don't understand everything it does. It's basically a collection of about 9 different peptides that are cytotoxic, cell damaging, and cause inflammation.
What kind of molecules are we talking about?
Researchers have identified things like alkaline phosphatase, hyaluronidase, phospholipase D, which we'll come back to, metalloproteases, serine proteases, a whole cocktail.
You mentioned hyaluronidase. Is that important?
Yeah, it's part of what's called the spreading factor. Enzymes like hyaluronidase make up almost all the venom, like 99.8% of the crude venom.
Wow, nearly all of it.
Yeah, and their job seems to be helping the other toxins spread out into the tissue more effectively. It's like the delivery system.
So the stuff that actually causes the skin necrosis, the damage.
That's the skin necrotizing factor, or SNF. And that's only about 0.02% of the venom volume. Tiny amount, big effect.
And how does it mess with our bodies?
Well, it disrupts the normal immune response. It stimulates the endothelial cells lining blood vessels and kind of throws off the way our polymorphonuclear cells, or PMNs, react.
Okay. And you mentioned hemolysis earlier, red blood cell breakdown.
Yes, there's a protein in the venom that can cause hemolysis. It needs calcium to work, it's heat labile, and seems to work best at a specific pH, around 7.1.
And that phospholipase D, you said we'd come back to it.
Right. Phospholipase D, sometimes called sphingomyelin DD. This one's probably the most studied component. It's a major player in causing damage.
How so?
It triggers the formation of tiny blood clots, microemboli, in the small capillaries. These clots block blood flow.
Which leads to tissue death.
Exactly. Deprives the tissue of oxygen and nutrients, leading to necrosis and those characteristic slow-healing ulcers, especially in areas with more fat.
And it does more than just clot, right?
Oh, yeah. It also activates parts of the immune system, the complement system, PMNs, platelets. And interestingly, it can directly break down red blood cells itself, even without the help of the complement system or the cell's own energy. It's quite potent stuff.
Potent indeed.
Yeah.
Is there like a difference between male and female venom?
There might be. Some evidence suggests females could have about twice the venom concentration as males.
And can we become immune?
It seems humans can develop some active humoral immunity, meaning our bodies can learn to fight it off better over time with exposure, but it's not really well studied.
So no vaccine or readily available anti-venom here?
No protective immunization exists currently. And while an anti-venom for a related South American species, Loxoscelism, exists, there isn't one commonly available and used for L. reclusa here in the U.S.
Okay, so limited defenses. Which brings us to diagnosis. Sounds like it's not exactly straightforward.
Not at all. You're absolutely right. The gold standard technically is catching the spider and having an expert ID it.
But that rarely happens.
Very rarely. So most diagnoses are presumptive. They're based on the patient's history, if they felt a bite, where they were, and the signs and symptoms that develop.
Like that red, white, and blue sign.
Exactly. But even with a likely story and classic signs, studies show that in only a very small percentage of suspected cases is the spider actually found or the bite confirmed. There's a lot of assumption involved.
Any specific diagnostic tests doctors can run?
There have been some developed, like an immunologic test by Berger and some ELISAs that try to detect venom antigens in tissue, but they aren't widely available or routinely used in clinical practice.
Which probably leads to a lot of misdiagnosis.
Oh, hugely. Loxoscelism, the reaction to the bite, can look like so many other things.
Like what? Give us some examples.
Okay, bacterial infections like staph or strep are common misdiagnoses. Viral infections like herpes simplex or shingles, diabetic ulcers, fungal infections, pyoderma gangrenosum.
Wow.
Even things like chemical burns, severe poison ivy reactions, certain types of vasculitis, syphilis, Stevens-Johnson syndrome, even skin cancer sometimes. The list is long.
So ruling things out is critical.
Absolutely. You also have to differentiate it from other bites, snakes, ticks, scorpions, other spiders, and non-bite causes like foreign body reactions, trauma, injection reactions, or emboli. It's a diagnostic challenge for sure.
So if a bite is strongly suspected, what lab work might be done?
Usually standard blood tests, a complete blood count, or CBC, electrolytes, glucose, kidney function tests like BUN and creatinine, clotting times protime, PTT, fibrinogen, and a urinalysis.
What might they show?
Well, if there's systemic involvement, you might see leukocytosis, a high white blood cell count. A falling hematocrit could indicate hemolysis, that red blood cell breakdown.
And signs of hemolysis itself.
Yeah, you might see increased plasma-free hemoglobin, decreased haptoglobin, and hemoglobinuria hemoglobin in the urine. Those are red flags for potential kidney problems, which can happen with severe hemolysis.
And hemolysis is more common in kids, you said.
It seems to be, yes. Rarer in adults, but definitely a concern, especially in children.
Okay, so the reaction can range from almost nothing to really serious systemic stuff. What does a more typical progression look like?
Right, there's huge variability. It depends on venom amount, bite location, fatty areas like thighs or abdomen often react worse, and the person's immune system.
Many bites just don't cause much trouble.
Exactly. Many might go unnoticed or just cause a mild local reaction without those classic changes or systemic effects.
But if it does progress, what's the initial feeling?
It might be unnoticed, maybe a slight sting. Often it's actually painless at first. Then, maybe 2 to 8 hours later, a sharp, penetrating, burning pain starts to develop.
Delayed pain. Why?
The theory is it's driven by cytokines, inflammatory chemicals released by the body in response to the venom.
Okay, so pain sets in. What else?
Usually localized redness, erythema, itching pruritus, and swelling around the bite site.
And then comes that characteristic sign.
Yes, the red, white, and blue sign, typically within 12 hours or so.
Yeah.
The central area becomes dusky, maybe purplish or bluish looking mottled. Around that, there's often a ring of paleness or whiteness due to ischemia, reduced blood flow, and surrounding that is a larger area of redness.
Red, white, and blue. Got it.
Over the next few days, that central bluish area sinks in a bit and becomes clearly necrotic dead tissue. That pattern helps distinguish it from some other ulcers.
What happens after that forms?
Blistering is common. Then, usually within a week or two, that necrotic tissue forms a hard, dark scab called an eschar.
Okay.
Eventually, the eschar slows off, leaving an ulcer underneath.
And healing. Is it slow? Does it scar badly?
Healing is typically slow, yeah. Often takes 6 to 8 weeks, sometimes longer. It heals by secondary intention, kind of filling in from the bottom up. If it's left alone, scarring can actually be minimal for smaller lesions.
But bigger lesions?
Bigger lesions, especially in those fatty areas, can definitely lead to more significant scarring. And sometimes, rarely, the ulcer can spread, getting quite large, maybe over 10 centimeters, sometimes even deeper into muscle.
You hear figures like 10% of bites cause serious skin damage.
Yeah, that figure gets quoted, but it's probably unreliable, likely inflated because of all the misdiagnosis issues we talked about. The true rate of severe dermonecrosis is hard to pin down.
Right. And beyond the skin, the systemic effects. You mentioned fever, chills.
Yes, less common, but more frequent in children. Usually starts a day or two after the bite. Fever, chills, headache, nausea, vomiting, just feeling generally unwell, sometimes a diffuse, itchy rash, joint pain.
And really serious stuff.
In severe cases, you can see thrombocytopenia, low platelets, DIC, which is a serious clotting disorder, and that significant hemolysis leading to hemoglobinemia, hemoglobinuria, potential renal failure, and very rarely death.
Are there ways to classify how bad a bite is?
There are a couple of classification systems, like the Wilson-King or our Hershey systems, that try to categorize severity based on signs and symptoms. But honestly, predicting who will develop serious illness is still difficult, and not every case fits neatly into a box.
Okay. So, given all this complexity and the range of outcomes, how do we actually treat these bites? Sounds like there's no magic bullet.
Definitely no magic bullet. There really isn't a consensus recommendation or a single definitive therapy. People have tried all sorts of things.
Like what?
Well, hyperbaric oxygen, which we'll focus on. Dapsone, antihistamines, antibiotics, dextran, corticosteroids, vasodilators, heparin, nitroglycerin, even things like electric shock or surgical excision have been reported.
Wow, quite a list. So what's the standard approach then?
The mainstay really is supportive care. Keep the limb elevated and immobilized if possible. Good local wound care, keep it clean. Make sure tetanus immunization is current.
What about ice? People often put ice on bites.
Interestingly, ice is generally not recommended here. The concern is it might further reduce blood flow to an already compromised area.
Okay, no ice. Pain management.
Yes, systemic opioids might be needed if the pain is severe. And antibiotics only if there are clear signs of a secondary bacterial infection, not routinely.
Got it. Let's talk about some specific treatments mentioned. Dapsone comes up a lot.
It does. Dapsone is an antibiotic, but also has anti-inflammatory effects. It's thought to inhibit certain pathways used by neutrophils, those PMN immune cells, potentially reducing tissue damage.
But it has risks.
Yes, a significant one is hemolysis. It can cause red blood cell breakdown, especially in people with G6PD deficiency, a genetic condition. It can also cause methemoglobinemia.
So does it work?
Well, there was an early successful report back in '83, and one study suggested it might be better than early surgery. But subsequent animal studies and human reports have been pretty inconclusive. There aren't good prospective human trials showing clear benefit.
So not a standard treatment then?
Generally, no, not for significant bites or systemic symptoms, given the risks and lack of proven efficacy.
Okay. What about steroids? Glucocorticosteroids like prednisone?
They're sometimes used, especially in South America, for the systemic effects, the systemic loxoscelism. The idea is, if given early, they might blunt the immune overreaction and potentially prevent severe hemolysis and kidney injury.
But they don't help the skin lesion.
Doesn't seem like it, no. They don't appear to halt the skin ulceration process. There's no standard steroid or dose, but a reasonable range is often used, and treatment duration depends on symptoms and resolution of hemolysis.
Any other drugs tried?
Cyproheptadine, an antihistamine, and nitroglycerin didn't show benefit in animal models. Electric shock therapy also didn't pan out. And like we said, the specific L-reclusive antivenom isn't available here.
Right. What about cutting out the bad tissue? Surgery.
For most bites, surgery isn't needed. An early excision, cutting it out soon after the bite, is generally thought to be ineffective, maybe even harmful.
Harmful? How?
It could potentially increase inflammation and delay healing unnecessarily. Many wounds, even fairly large ones, will heal fine on their own with just supportive care and time, often with minimal scarring.
But sometimes surgery is needed later.
Delayed surgical debridement, cleaning out clearly dead tissue, might be considered for wounds that are very slow to heal. Skin grafting is rarely needed, and some believe hyperbaric oxygen might help avoid it altogether.
Okay, that brings us nicely to hyperbaric oxygen. HbO2. How might that help with a brown recluse bite?
Right, HbO2. The main idea is forcing more oxygen into the tissues under pressure. This could help oxygenate tissues that are ischemic, starved of oxygen, due to those microclots caused by the venom.
Makes sense. Any other potential mechanisms?
There are a few hypotheses. One is that HbO2 might directly inactivate some venom components. Maybe that's sphingomyelinase D, although one animal study didn't confirm that. It might also interfere with sulfhydryl groups thought to be involved in venom toxicity. Plus, HbO2 is known to reduce inflammation, stimulate angiogenesis, new blood vessel growth, and potentially decrease the overall effect of the envenomation.
So multiple potential benefits, but the exact mechanism isn't totally clear.
Pretty much. We don't have the full picture yet.
What has the research shown? Let's start with animal studies.
It's a bit mixed, honestly. Some studies, particularly one in rabbits by Maynor and colleagues, showed significant benefits. They used a specific protocol, 2.5 times normal atmospheric pressure for 90 minutes, twice a day, starting 48 hours after the bite, and saw much smaller lesions and less necrosis.
But other studies?
Other studies using different animals like piglets or guinea pigs, and different HbO2 protocols, different pressures, timings, frequencies have had conflicting results. Some showed little or no benefit compared to controls or other treatments.
So the details of the HbO2 protocol might really matter.
That seems plausible, yeah. The pressure, duration, how often it's given, when it started, all these factors could influence the outcome.
Okay, what about human data? What have we seen in people treated with HbO2?
Well, the human data is mostly case reports and case series. No large randomized controlled trials, unfortunately, so you have to take it with a grain of salt. Often, patients received other treatments too, which complicates things.
But what do those reports suggest?
Some early series, like one by Svensson, reported prompt healing. A larger unpublished series mentioned a very low need for skin grafting in patients treated with a protocol of typically 2.0 ATA for 90 minutes, once or twice daily, averaging around 6 treatments.
Any notable cases?
Maynor's group also reported human cases healing well without scarring, disability, or grafting. There are reports of successful treatment for bites in tricky areas, like the penis or around the eye.
Does it have to be started early?
Early seems better, but interestingly, there are reports where HbO2 was started weeks, even months, after the bite for non-healing ulcers, and it still seemed to help kickstart the healing process. Leach and Hadani reported cases like that.
So, based on all this, what's the practical recommendation for using HbO2?
Well, given the lack of definitive trials, it's not routine, but if you have a strong presumptive diagnosis, especially if the lesion looks like it's progressing, initiating HbO2 early, say within the first 48 hours, is considered reasonable by some.
What kind of protocol?
A common starting point might be twice daily treatments at 2.0 ATA for 90 minutes. The number of treatments varies hugely, maybe averaging around 6, but could be anywhere from 2 to over 20 depending on the response.
And you reassess after each treatment?
Absolutely. You monitor the wound closely, see if the inflammation is decreasing, if the necrotic area starts spreading. HbO2 wouldn't necessarily exclude other supportive therapies either.
And it might still be an option for later non-healing wounds.
Yes, the evidence suggests it can still be beneficial for those chronic stubborn ulcers that just aren't closing up.
Do people usually need to be hospitalized for this?
Not necessarily for the HbO2 itself, unless the bite is severe or there are systemic symptoms requiring hospital care anyway. Monitoring the lesion and any systemic signs is key, and follow-up is typically outpatient.
Okay, let's try to wrap this up. What are the main takeaways here?
First, diagnosis is really tricky. Don't assume every nasty lesion is a brown recluse bite, especially outside its main territory.
Right.
Second, most bites are actually pretty benign and resolve with simple supportive care. The biggest worry is severe hemolysis and systemic complications, which are rare but serious.
And treatment. especially HBO2.
The evidence for any specific treatment beyond supportive care is limited. For HBO2, it's mostly anecdotal case reports, small series, no big human trials, lots of confounding factors, different protocols used.
But there's a suggestion of benefit.
Yes, reports consistently suggest HBO2 might help heal ulcers faster, potentially reducing scarring and the need for surgery. Some doctors even report seeing the color of the lesion improve during the treatment itself.
So the final verdict on HBO2.
Look, while it theoretically could reduce morbidity, the lack of strong, conclusive human studies means it shouldn't be considered a routine, automatic treatment for every suspected brown recluse bite.
You need more research.
Definitely. Future research really needs to focus on well-designed trials to figure out what truly helps limit the damage using optimized, consistent protocols.
It's a really complex picture for such a small spider. A fascinating deep dive, even if it leaves us with some lingering questions.
Absolutely. It shows how much we still have to learn, even about relatively common medical issues.
And for you, our listener, here's something to think about. Given how variable the bites are, how complex the venom is, what other factors, things we haven't even touched on perhaps, might influence just how bad a bite gets and why some treatments might work for one person and not another. Definitely some food for thought there. Join us next time for another deep dive.